Our next session is called Triumph on the Trail, Advances in Early Stage Non-Small Cell Lung Cancer. This is a really important session. We've gotten off to a super strong start this morning. Dr. Camage was so inspiring and gives us motivation for the rest of the weekend. We have our wonderful survivor moderator, Sharu Nair. Give a wave, Sharu, let everybody see who you are. She'll be helping with our question and answer session. And we have excellent presenters for this session joining us. Dr. Eric Singhi, thoracic medical oncologist at University of Texas MD Anderson. He's known especially for his work in patient education and caring for young cancer patients. You all know him as the Lung Doc on TikTok. He will be joined by Dr. John Waters, who is an assistant professor of thoracic surgery at UT Southwestern here in Dallas. He specializes in lung cancer and minimally invasive and robotic-assisted procedures, helping to bring cutting-edge surgical care to our early-stage patients. And Dr. Zach Brownlee, of North Texas native and radiation oncologist with the Center for Cancer and Blood Disorders. He is known for his patient-centered approach. I will tell you that his nurses gave us the heads up on Dr. Brownlee that his patients love him. So we are grateful to have his dedication from our local community. You can read their full bios in the app. And now let's give that big Texas welcome to our next session.
People in Texas sure do make you feel at home.
All right. Thank you, Anne. Thanks to Longevity. Thank you all for being here. I don't normally like being behind the podium, so I'm just going to come a little bit forward so I can talk to you guys. So my name is Eric Singhi. I'm a thoracic medical oncologist, so I treat patients with lung cancer in Houston. Welcome to Texas. The weather is much better than it was yesterday, so excited to be able to hopefully have some time outside and enjoy it with you and your loved ones. So my job today is to talk about early stage non-small cell lung cancer. What does it mean? And essentially help Dr. Waters make his presentation a lot more understandable and digestible for you guys. So I'm going to give you all the terminology, all of the lingo that you need to know. So if you were here last year, you'll notice that some of these slides have been repeated, but I tried to add to them and distill more information. So really what I should be saying is we're saying bye-bye-bye to early stage non-small cell lung cancer. If you've seen me on social media, you know I've done videos about this as well too, to try and help you guys understand the terminology. These are my disclosures. Okay, so we have a pretty packed agenda for these 15 minutes. We're going to talk about what is early stage resectable non-small cell lung cancer. We'll talk about how you stage non-small cell lung cancer, why what Dr. Waters does, no offense taken, but why sometimes surgery alone isn't enough, right, for patients? What are these key terms to talk about? Molecular testing, how does that impact your treatment plan, and what to do after your treatment. So let's start off with what's early stage non-small cell lung cancer, NSCLC, that's the abbreviation that we use. Before we get into early stage, let's just talk about lung cancer in general. As you guys know, lung cancer is one of the most common cancers worldwide, and non-small cell lung cancer makes up the majority of lung cancers. It makes up 85% of cases. And I really want to emphasize this, that all you need to be at risk for lung cancer is to have lungs, right? There should be no stigma or blame. About 20% of patients being diagnosed today have never touched a cigarette, have no personal smoking history. When we talk about early stage non-small cell lung cancer, the definition is a little bit different for medical oncologists than surgeons, and Dr. Waters can talk about it. But what we're talking about today, early stage non-small cell lung cancer, it makes up about 25% of cases of non-small cell lung cancer in general. And when we're thinking about early stage non-small cell lung cancer, we say that the cancer is still localized. It's in the lung, possibly involves nearby lymph nodes. That's where lung cancer likes to move to those lymph nodes that are nearby. And if the cancer can be safely removed with surgery, that's when we call it resectable. And of course, that depends on the surgeon's evaluation of the case and the patient. So Dr. Waters ultimately helps make that call. And at this stage, our goal for patients is often to aim for cure. And that's really important to understand the treatment goal. So let's talk about staging basics, and I'm going to give you a few examples. So stage 1 is typically when there's only tumor present in the lungs. So what I'm showing you is a CT scan. So if you look at the CT scan, imagine that I'm laying there with my feet coming out of the screen. So the left side is the right side and the right side is the left side. It's flipped. And basically my body is being cut into a loaf of bread, slice by slice by slice. And what you're seeing is a slice of the lungs. And you can see that the red circle there, that's showing you a tumor. So this tumor is present only in the lung. That's typically stage 1 disease, and surgery is really what we recommend for patients, for most patients in this case. Stage 2 disease means that the tumor is in the lung, but it's also traveled nearby to some lymph nodes. And so you can see that picture there on the bottom left. You can see the really bright tumor that's on the PET scan, and then you can see that there's also a little brighter area to the right of it, and that's concern for lymph node disease. Stage 3 disease means that the tumor is typically larger and typically can have more lymph node involvement. So you can see a picture on the right there that shows a pretty large, bright tumor that's there on the left side of the lung. But it's really important to understand that stage 3 disease, that's probably where there's a lot of variability. And so that's where, we not only talk with Dr. Waters, but we talk with Dr. Brownlee. We have a multidisciplinary team to figure out what's the best path for a patient. So knowing the stage is really important because it helps us choose the best treatment plan for you, including whether we need to give you medications before or after your surgery. So why is it important to be thinking about what else to do besides surgery for patients, even if you can go for surgery? So even if Dr. Waters comes in, your surgeon removes the entire tumor, the big concern is for what we call microscopic cancer cells. So these are cells that are too small to be detected by the naked eye on your imaging. And what we're concerned about is that even if Dr. Waters goes in, he removes the tumor, is that there may still be some of these very, very small cells left behind in the body. And then what happens is these cells can grow or spread later if we don't treat them. So what have been the rates for patients if they go for surgery? We look 5 years out or 5 years later and we say, what's the chance of the cancer coming back? We call that recurrence. Historically, the rates of cancer coming back after surgery for stage 1 disease is almost about a quarter of patients. For stage 3 disease, you can see almost 3/4, 70% of patients may have their cancer come back within 5 years. But we are trying to do better, and that's really the whole point of our conversation today. That's the point of the HOPE Summit. That's to show you that there have been advancements in this space. And that's where medical oncologists like myself come in to talk about using drug treatments to lower that risk. So we're going to talk about that. So I want you to think about cancer causing this storm in the body, right? And the storm, when you have a storm, it leaves a lot of debris, leaves a lot of tumors, leaves a lot of a mess. So I want you to think of this as cleaning up after a storm. So Dr. Waters and the surgery team after a storm will come in and they'll take out the big damage, right? And so you can see that the big damage after the storm has cleared is being taken away by the surgery. But the problem is that you may still have these tiny pieces of debris that are left behind. That's where medical oncologists, the cleanup crew, can come in, right? And after the surgery has been done, they can help take that hidden debris away. And that's what's really important, working together to come up with this plan. And so we want to make sure that we're taking away not only the really large disease, the storm that has caused, but also the hidden debris that might be left behind. So I want to explain some of the terminology because it can get really confusing with all the terms that we throw around. And Dr. Waters is going to use a lot of these terms before his talk. So let's go through this together. Really, what I want you to understand is that these key treatment terms are all about the timing of when you get your treatment, when you get your drug treatment. So one term that we use a lot is called neoadjuvant. What it means is treatment before surgery. And the goal of treatment before surgery is to try and shrink your cancer, try and shrink that tumor, one, to help make the surgery hopefully easier, and then to also make it more effective by removing as much cancer as possible beforehand. Then there's a term called adjuvant. Adjuvant means treatment after surgery. And that's to reduce the risk of the cancer coming back. That's really the goal of the adjuvant therapy. And then you can have a combination of both neoadjuvant therapy and adjuvant therapy, which we call perioperative, and that's treatment before and after surgery. And the goal of that is to shrink the tumor before surgery and clean up any remaining cancer cells, maybe even those microscopic cancer cells that get left behind. So I want you to think about perioperative therapy as a sandwich approach. And I'm going to walk you through this. Okay, so here is the meat patty. I'm vegetarian, so maybe this is a black bean burger is what we'll say. But there's the surgery, right? It's right in the middle. And the goal of the surgery is to remove all of the visible tumor, but the concern is that there may still be very small cancer cells left behind. Now we've got the top bun, and that's neoadjuvant therapy. That's treatment before surgery. Again, it's to help shrink the tumor as much as possible, make that surgery as effective as possible. And then we've got the bottom bun, adjuvant therapy, treatment after surgery. And that's to treat after surgery, destroy any remaining cancer cells that are left behind. And so this is the perioperative sandwich, and now I'm hungry. So sorry to make you guys hungry. Hopefully you had breakfast, and lunch will be soon. So we'll keep talking a little bit more about some of these terms. So what's really important to understand is the response to the drug treatments that patients get is determined after they go to surgery. What happens is the pathologist will look at the tumor that's removed, the lymph node that's removed, and see how well did my drug treatments do. The ideal goal situation is what we call PCR, pathologic complete response. That means that once the surgery happens and the pathologist is able to look under the microscope and see how many of those cancer cells are alive, there are no cancer cells that are still alive, that are still viable, found after getting systemic therapy. And then there's something called MPR, major pathologic response. That means that when they look at the tumor sample after surgery, less than 10% of cancer remains alive. And that's also a very good goal. I'm telling you these terms because we're starting to learn that based on these responses, they can be strong predictors for how patients do long-term, for long-term survival. I want to talk about molecular testing. If you guys have seen anything I do on social media, on the stage, in the podium, on publications, I talk so much about biomarker testing, molecular testing, and this is incredibly important, not just for patients with stage 4 disease, but early stage disease. So yes, molecular testing matters. It's really important before you decide on the best treatment to get molecular testing done. There's a lot of names and synonyms for this, guys. So if you hear biomarker testing, molecular profiling, genetic testing, those all tend to mean the same thing. These tests are typically done on your surgical sample, so after you have your surgery, or ideally even on the biopsy sample when you first find out that you've been diagnosed with lung cancer. The problem is that getting all these results can take time. As of right now, on average, it takes about 3 to 4 weeks to get all those results, and they can come back fragmented. But it's really important to get these results because without these results, we might miss the opportunity for a more effective treatment or even a less toxic treatment for you. So what are we looking for from these molecular tests? Right now, what is mandated, what is absolutely essential, is looking for certain mutations or alterations called EGFR and ALK. That's in that blue row there in the table. This helps us decide if you may qualify for a targeted therapy that's already approved. We're also looking at a protein marker called PDL1, and that's on your tumor cells, and it helps us guide and think about immunotherapy for your case. And then I would also advocate for looking at other mutations. We're going to have a whole session later this afternoon about all the different types of alterations, actionable genomic alterations that can happen in non-small cell lung cancer, like BRAF, MET, KRAS. Those are still really important in this case because they can help you think about clinical trials, and they can help us think about what to do in the future if, God forbid, the cancer comes back, right? So having that plan B, C, and D ready to go. So I want you to think a little bit about using all this information to build your treatment plan. So for most patients with early stage resectable non-small cell lung cancer, treatment may include surgery, may include medical treatments such as chemotherapy, targeted therapy, immunotherapy, even clinical trials, right? There are trials in this space too. And then what's also important is what comes afterwards, monitoring and follow-up. I want to emphasize that the plan is personalized, yes, on your cancer stage, your type, the molecular profiling, but it also needs to be personalized based on the patient, right? So we don't just treat cancer, we're treating the patient with cancer. And so we need to account for their overall health, we need to account for what your patient goals are, and make sure it all comes together. So what's been approved over the last 5-6 years in this space? So this is a table of all the FDA approvals that have happened in this space: neoadjuvant, perioperative, adjuvant therapy. In the red box, you can see some targeted therapies that have now made their way for FDA approval. What I'll tell you here is before 2020, if I was asked to give this talk 6 years ago, the only thing I would have on here is chemotherapy. And so this is why clinical trials are so important and why research matters, because look what's happened in the last 5 years in terms of approvals. I want to talk a little bit about monitoring after treatment. I know we're going to have some questions about this afterwards too, but even after your treatment ends, you're not getting away from your team members, okay? We need to stay closely involved. So we typically talk about using CT scans for monitoring every 3 to 6 months for the first 2 years. You need regular blood work. You need to be seeing your physician, have a physical exam, talk to them about how things are going, those routine checkups. And it's really important to have these follow-ups planned because the key to catching any recurrence is hopefully to do that early. I did list some questions here to ask your team. I want to make sure I'm respectful of the time that we have for our other colleagues here, but I know they're going to give you guys the slides. But these are some questions to ask your teams in terms of cancer details, in terms of if you're going to go for surgery, can surgery be a part of your treatment plan? And then how the surgery is going to go. How are you going to recover? What's the surgical procedure like? And then what to do after surgery, follow-up and monitoring, asking for support, right? Being connected with a community that can help you. So in summary, early stage non-small cell lung cancer is something that can be surgically removed and is often treatable with a goal for cure. Treatment includes surgery and medications to reduce that risk of the cancer coming back, which we call recurrence. It's incredibly important to have biomarker testing, molecular testing, PD-L1 testing to help us personalize your treatment, personalize your care, even for early stage disease. And what Dr. Kamich said very nicely, and Anne continues to emphasize throughout this, you are not alone. You have your community, but you also have your care team, and we're here to help you through every step of the way. And so there's absolutely hope in early stage disease. There is a plan, and you're going to have a team by your side. With that, I will hand it to Dr. Waters.
Thanks so much. I have to check out your TikTok page. That sounds exciting. My wife is a huge New Kids on the Block fan, so no offense to NSYNC, but I was going to talk about treating localized lung cancer just from a perspective of a thoracic surgeon. The disclosures here is there. I thought I'd break this down into just 5 categories. And, to Dr. Singhi's point, this is not a single-person sport. This is multiple people working together in different specialties and people talking to one another, and really how multidisciplinary treatment of lung cancer has become over the last 20, 30 years. I broke this down into 5 categories. So I thought the things that were probably most helpful is what's changed is not only surgery, but kind of what gets you to surgery and then what happens after surgery. And surgery is just one part of what you're doing. And I think sometimes in the past, surgeons had a tendency to say we're sort of the center of attention, but that's really not the case. If you happen to get to surgery for lung cancer, I try to tell people that surgery is not the defining point of your life. This is just something you pass through, you walk through, we try to remove the tumor as best we can. But Dr. Singhi's point, if you think about what's happening a lung cancer is in your lung. And the lung is being perfused by blood, it's being drained by blood, and that blood is circulating through your body. And just because you take out the tumor, you take out the lymph nodes, that's not to say that you don't have leftover cancer in your body. And when you're thinking about, I thought you were going to say when you had the surgery was the cleanup, I thought surgery was the storm. I mean, sometimes, holy bananas, I mean, people come into surgery and we do the minimally invasive thing. I mean, this is traumatic. This is major trauma that you're doing to people. And I know this is videotaped, but we're essentially putting ports, which is basically impaling people. Or putting cylinders inside a patient's body. You're putting instruments through those things. And it's a little more sophisticated than the old way, but it's the same operation. It's the same trauma to the blood vessels, the same removal of the lymph nodes. And people are dealing with pain, and if you all have gone through surgery, you all know what I'm talking about. We give you nerve blocks and pain meds, but it is quite an ordeal. Just thinking about this, Dr. Singhi did a great job. 250,000 people in the United States get lung cancer. It's the #1 cancer killer in the United States. This is the breakdown, as he talked about so well. These are just some pictures of what cancers can look like. Those are explants on the right, and then that's just a live view inside of someone's chest. Survival is dictated by stage. What's really changed is the improvements in getting a surgical biopsy. The challenge is someone gets a CT scan for whatever reason. A lot of these things are found incidentally. How do you know what's going on in a patient? We have risk calculators to try to help you work through. We try to have algorithms to try to minimize patient risk to get a diagnosis. To get diagnosis, this is just a little slide about how it's progressed over the last 50 years. Bronchoscopy in the 1960s, needle biopsy in the 70s. You have endobronchial ultrasound coming around the 90s. You have more advanced technique to get 2 tumors. And then you have these various technologies that are progressively getting better to get more tissue, to allow us to do molecular testing and things like that. But to be honest with you, we're really quite primitive in this. We've made progress, but I think probably one of the major advances is how to get tissue early, how to get enough tissue early, how to make sure the biopsy specimens are good. And you can see from this slide, this is just looking at robotic bronchoscopy, which is available in a lot of hospitals. There's great variability in the results that people are getting. And I don't know if anybody in here has undergone a biopsy. It's quite invasive, and then that's non-diagnostic, and then you got to wait for another biopsy, and then you got to try to figure it out. And there are issues that we run into. The improvements in getting enough tissue has been sizable, but also, timeliness. I mean, waiting 3 to 4 weeks for genetic testing, I mean, you got to be kidding me. Having non-diagnostic biopsies of trauma of that, I mean, there's opportunities in there. And access is not available to everybody. I mean, you think about 250,000 people have lung cancer in the United States. There's a lot of people that aren't getting timely care. I work largely it's part of my time at Parkland. People come in with stage 4 disease. They just didn't know. So there's improvement, but there's also opportunity. The improvements in localizing tumor technologies, I think that's another thing that's gotten better. It may sound so silly to you that in the 21st century, finding the lung nodule sometimes can be a challenge. And if you have a patient who you're trying to do a less than a lobe resection on, sometimes one of the darndest things is trying to figure out where this thing is. You're trying to find it on a CT scan. Sometimes it's deep in the lung tissue, and it can be difficult to place it. There's all sorts of different ways that people are doing this. We can inject dye. You can put things through the bloodstream. You can put needles and wires through a patient's body. And I think that's probably one of the advances, is that we're moving things forward to be able to localize things and actually coming down to where you can give a metabolite to a patient through the vein, and that can help you find it. And this is just an article my boss had put together about that. The improvements, it's easier to find things now, but still timeliness is an issue. There's variable institutional experience, there's variable access. Sometimes with these localization things, there's false positives and false negatives, so opportunities for improvement. Minimally invasive surgery and the feasibility of reduced surgical resection, I just put those things together. This is another diagram to show you the history of taking out tumors for lung cancer. It started in the 1930s. That little picture at the top is his name's Everts Graham. He was a chest surgeon at WashU in St. Louis, and he was one of the people that identified cigarette smoking as a risk for lung cancer. You see all those cigarettes smoking in front of him. He actually connected those to pipes and pushed the smoke, the metabolites, into a rat cage, and that's how they identified that lung cancer could cause cancer. Cigarette smoking could cause lung cancer. He started by taking out the whole lung on patients in the 1930s, and that was the standard of care for about 20 years until after World War II. A group of surgeons, I think they were up in Boston, started taking out just the lobe on people, and there was like fights at the thoracic surgery meetings because there was a camp that said you got to take it all out, and then a camp that said take less of it out. And the guys who said take less of it out, and most of it was guys at that time, they were right. And then over the course of the last 30 years or so, we're trying to take out less and less lung tissue. The options to take out lung tissue go from wedge, which is like taking out an orange slice of a lung, versus a segment, versus a lobe, and then more advanced stuff. This is just a picture of what Graham's patient looked like in the 1930s. You see a big slice along the back shoulder blade, and then this is just small incision surgery that's done in most places today, but and mostly feasible for a lot of cases, not all, however. We have robots now, not R2-D2 and C3PO, but I don't know. Robots are good. Robots are an opportunity to reduce trauma, but still it's quite a traumatic kind of thing. I'm going to go through this. This is just showing some of the data that oncologically, if you have tumors that are less than 2 centimeters, you may be able to preserve more lung tissue while reducing recurrence. Key challenges with surgery is it worth it? The trauma question, is a patient strong enough? We don't want to hurt people as we do surgery, so making sure people could tolerate the trauma of surgery. The key question is how much is enough? And then the risks of repeat surgery. And then the last is a multimodal treatment strategy. I mean, Dr. Singhi could speak to you way better than I could about this, but there are great opportunities to try to be helping patients to improve their outcomes and their long-term survivals, quality of life with some degree of neoadjuvant, as he talked about. The sandwich idea that's pretty cool. I like that idea. And it's real important because you have some cancers that may not be resectable, but may become resectable with preoperative therapy. finding the best sequence is a challenge, and there's certain risks associated with everything that we do. I think probably as a conclusion for the surgical side of things is things have changed, and for the better for a lot of different ways for a lot of different patients, but we still encounter great challenges with surgery. Surgery is certainly no walk in the park. It's very helpful to have a care team that really has experience with it, people that can help you get through it from a pain perspective, as well as sometimes you have intraoperative issues, and people can help you get through. And I think probably the most substantive thing is for anybody who happens to have a lung cancer, try to keep the main things, and the plain things, focus on stage, focus on finding a group that can help you expeditiously, focusing on a place that can offer you different treatment options. And that's in this area and around the country, that's actually quite available. And then to also recall that we are all trying to help one another, and it's not you're going to a surgeon's office and just getting cut on and that's it. There's real importance for patients to have long-term follow-up and a care team that can help them. And actually the patients help us, honestly, probably more than we help them. We're just offering a service to try to get them through an operation safely to take a cancer out. But we learn from the patients all the time, and things that they tell us we can use to help other people, and then also the ways people are donating tissue for research and opportunities to make advances. So to all of you, just hang in there. And people that have, I think I heard someone say before that the sphere of lung cancer has really changed, right? It used to be really a fatal disease, and then now it's sort of a disease people live with at a reasonable quality of life for a long period of time. So hang in there and just keep going with what you're doing.
Can you guys hear me? Thanks. So I'm Zach Brownlee. I am a radiation oncologist that practices across town in Fort Worth. Thanks for having me here. So I think from the previous two talks, we've learned that even for early stage non-small cell lung cancer, this is a team approach. So I'm kind of the third tool in the toolbox with radiation therapy. So I kind of broke my talk down into very early stage. So typically for me, this is patients that are non-operative. That can either be from the tumor size, so the number of lymph nodes, the location of the tumors, if they're very near kind of where the airways open up, sometimes surgery is not safe or not feasible, or it can become from a patient standpoint, their comorbidities, their age, their cardiac function, and most importantly, their pulmonary function. A lot of patients that do have lung cancer do have of their comorbidities like COPD, where surgery could be harmful to their function or not survivable, but we do have a good option with non-invasive managements with radiation therapy. For more advanced stages, sometimes we need our chemotherapy colleagues to help us with the radiation therapy we deliver so that it can be effective and safe. So for the early stage, our tool of choice is this thing you've heard of called SBRT, which was actually pioneered by Dr. Timmerman, who works at UT Southwestern here. So this is a term that stands for stereotactic body radiation therapy, which is a fancy way of saying very high dose, very conformal treatment. This is like I have here, a non-invasive, ablative, or curative treatment technique. This is ideal for non-node involved cancers that are typically smaller. The size is kind of a moving target. I treat pretty big tumors when we don't have good alternative treatments. This is delivered usually in 3, 4, or 5 fractions when we're treating in the chest. There are some single fraction approaches for other body parts, brain, kidney, and occasionally in lung, but not that I typically do. For my case, almost everyone is a candidate. So I get PFTs, I do the workup, but pretty much anyone is a candidate, except for a very few scenarios. The beauty of this treatment is it has a very low toxicity profile. Most cancer treatments, we say, don't always come risk-free, and this one is not risk-free, but most patients really fly through this treatment. And we also have excellent local control, so we're trying to mimic what the surgeons do without the knife. Just go over some basics of radiation, since for some patients this is a kind of foreign topic. Big picture, the workflow, we start off by getting the diagnosis. So there's imaging. Often that includes a PET scan to try to image the body, potentially an MRI of the brain, depending on the kind of advanced findings in the chest. And then we kind of rule out surgery. So we do the surgical workup. We get cardiac testing. We get PFTs from our pulmonology colleagues. And we decide, usually in a multidisciplinary approach, which even in the community we're getting better about having these. We have tumor boards. We have conferences where the radiologist will present the imaging, pathologists show the diagnosis, and then the care team will decide what's the best route for the patient. We try to have all the patients see all the specialists before we make a decision so they can hear about it, get the recommendations, and then ultimately choose the treatment they're most comfortable with. Part of the workup for me is important to have the nodes evaluated. We want to make sure if we're offering early stage treatment that the lymph nodes have been assessed. The surgeons can evaluate those when they're in doing the surgery. For me, I'm not going to go inside, so we try to get these EBUS biopsies if possible. Once you become my patient, our first step is to do what's called a CT simulation or a mapping session. In order for me to treat someone, I need them to lay in the same position every day, and we need a position that is reproducible. Depending on the complexity of the treatment, it could be laying on a black pad or it could be in a device. We then do a CAT scan in that position so that I can tailor the radiation to your body in that position. That often involves getting some tattoos that we use to set patients up in the room more quickly. Then I do all the magic behind the scene, which is my surgery, and while you guys are sleeping, hopefully. We get the plans ready, and then I have a team of physicists that will take my drawings on the scans and make the plans happen. Then we treat some dummies to make sure the plan is safe, and then we bring you in for treatment. The treatments are outpatient treatments, usually take around 10 to 15 minutes. They're painless, just like getting a CAT scan. Once we're finished, we get you back to see all of the team, and we do follow-up imaging like we've discussed. Some of the advances on the radiation standpoint, most of the research is more on the medical oncology side, but we are getting better with technology and science to try to deliver better, more conformal, more targeted radiation so we can have excellent local control and minimize the side effects. So one of the improvements in the chest realm is when we breathe, our lungs move. When our lungs move, these tumors can move. So we're trying to hit a moving target. So we have different devices and technology that the companies have developed that allow us to do this more safely. I have kind of different diagrams of different techniques depending on what technology you have and how able your patient is to have reproducible breathing or do breath holds. But in general, we're trying to treat as small of areas as possible to minimize dose to the lungs. This is just some pictures of what we see behind the scenes. So this is the software we use to plan the radiation. So I essentially draw like Microsoft Paint on scans of what everything is from my target to the normal tissues. My physicists will then take these series of goals that I give them and run an algorithm where we simulate how the radiation is deposited in the body, typically with thousands of beams coming from all along the body. Just like spotlights, they focus on the target. And we generate a plan. From that plan, I determine the ideal dose and number of fractions that can safely be delivered. Like I said, then we treat a dummy to verify that everything is safe and reproducible, and then we will treat the patient. As far as follow-up, my follow-up imaging is a little bit more complicated than the surgical patients. They see kind of post-operative changes. I can see this smattering of inflammation and tumor response and scar tissue that evolves over time. And there's always a little bit of guesswork. Like I tell patients, the lungs do not regenerate, so there's always going to be a mark of where the tumor was. So there's always a little bit of uncertainty. My typical discussion is this treatment tends to work quite well, so I really need to be convinced that it hasn't worked before we would start to worry. But when there's changes, we can always get PET scans. We have these new liquid biomarkers we can use for help, and we always have biopsies if we need to. The future directions in early stage, non-operative, non-small cell lung cancer is mostly potentially adding these systemic therapies with SBRT. We currently don't do the neoadjuvant or the adjuvant or the sandwich approaches, but these are being studied, and I suspect they will likely show some benefits, so that's probably where the future is heading. When it comes to more advanced disease, so these are So patients that have a little bit more disease, I can't safely do these really short treatments because there's too much normal structures in the field that could be damaged. So the principle of radiation that's been around for a long time is what we call fractionation. We break up the treatment into little doses that are delivered over time to build up to the full dose. In between each treatment, our normal cells are able to repair a lot of the collateral damage that we do, so this allows us to do it more safely. In order to get effective treatments, we often do this with chemotherapy delivered at the same times. Not every patient is kind of a candidate for this, so we have different strategies if they're not. The big change that happened when I was in training is the addition of immunotherapy after treatment, the Pacific trial that really did dramatically improve our outcomes. It's pretty rare. Adding a single drug to a treatment can almost double your cure rates, but that's what we're seeing. This treatment plan again looks the same, but you can see from my patient I have here, typically we're looking at a lot bigger volumes. We're including multiple lymph node stations, which is a lot closer to our critical organs. So we have a lot more that we're trying to avoid. I'm going to go back. Oh, I can't go back. So these cases are a little bit tougher. Since I'm treating a bigger area, we do have a little bit more side effects, which is where when you're on treatment, we see you weekly or as needed more often to manage the side effects. Surprisingly, radiation to the chest is quite well tolerated. The main toxicities with these treatments is often the fact that these lymph nodes tend to be near our esophagus, so we're dealing with kind of a sunburn in the esophagus that can cause pain with swallowing and difficulty getting nutrition in, which is typically the main side effect we manage, on top of some mild cough or fatigue. And depending on where the tumor is, you can get some skin reactions, but often these are fairly easier treatments to get through. For stage 3, this is where there's a lot of research going into this as well. Again, most of the trials now are on resectable patients, but these are areas where we're also looking to improve our outcomes here. We've added immunotherapy as kind of the maintenance or outback treatment, but we're looking at different combinations of drugs, especially with patients with targetable mutations, potentially getting those involved in this area as well. And then even in my practice, we're seeing patients that are getting neoadjuvant immunotherapy and they don't always get to surgery, and then we're treating them afterwards. So we're trying to learn if this algorithm is good as well. Typically for stage 3, we're trying to use 2 of the 3 tools, but occasionally we do need all 3, and we're finding ways that we can do this safely and effectively. So I just did a little AI search on all these trials. So just to show you, there's lots of things going on. So the future is bright, and we're learning more techniques. Just one last thing. I'd say a big part of this topic is just as a patient advocate, making sure that you get the opportunity to meet all of the specialists. A lot of pulmonologists will send you to the surgeons, and you might not see anyone else. So just knowing that I do think medical oncologists are important in every stage of lung cancer, even if they never treat you. I think they need to be part of the team. Another importance for community outreach is really getting lung cancer screening as to the forefront. I do a lot of marketing around here to primary care doctors, but lung cancer screening, CT scans do save lives. These early stage cancer patients, which I'm lucky to see a lot of, they do very well. The majority of my patients are able to be cured and live their life pretty similarly to they did before treatment. So trying to catch these as early as possible is key. The primary care doctors know, but they're busy. So just reminding people as a community in the lung cancer world, trying to spread the word. And then the second thing would be on, again, smoking cessation. The more we can get people to stop smoking, the less we're going to see of this, and the better they'll do when we do need a treatment.
Thank you. That was wonderful. Extremely informative. Thank you to each one of you, individually and together. So I wanted to kind of really be mindful of our time. There are a lot of questions here. We have roughly 15 minutes, kind of. And Anne is going to give me a 5-minute warning. Give us one. So one of the questions, and folks in the audience, please feel free to upvote the questions. I don't know if you've had a chance to know that you have the ability to do that, and that'll ensure that the ones that have the most need here to be answered can be handled. One of the ones that has been upvoted, of course, is dealing with the newest technologies like AI. And it says, how has the human genome mapping, AI like CRISPR, shown promise in genetic targeting or other advances in immunotherapy, treating lung-only nodules? And I'll just really ask us to be short on our responses so we can take, and at the end, if we haven't reached all of them, I'll try and consolidate 2 or 3 questions or give them to you together so you can provide at least everybody some answer if possible. Thank you. You're welcome to jump in as you would like.
Yeah, and I think this is a pretty broad question. It's exciting. We're constantly talking about using AI to help guide our treatment selection, to find biomarkers, to think about screening. So there's a lot of research that's happening in this space. Nothing prime time yet, but a lot of promising research in this space. So I would say stay tuned, but it's helping us think about finding these nodules a lot sooner, acting on them sooner, acting on them precisely. So stay tuned.
Thank you. Any other questions?
I also say for the AI for lung nodule, I mean, Dr. Brownlee's point is really important. Stop smoking and then finding the nodule screening programs. And then think about all the CT scans that get done and how many nodules are something and how many are nothing. And probably most are nothing. And having AI that can assist with determining, helping radiologists determine what needs to be looked at. This is important.
Thank you. Okay, good. There's a question here about do patients with oncogene drivers like EGFR and ALK have a higher recurrence rate than patients with no mutations?
Yeah, this is a good question. So for EGFR and ALK, we now have approvals, FDA approvals for what we call adjuvant therapy. Remember, guys, that's treatment after your surgery is done. You qualify for an oral targeted therapy, and that's really important because we found out that it's helping control the disease from coming back, and it's also helping patients live longer, particularly for the EGFR space. And so I would advocate to definitely talk about adjuvant therapy, systemic therapy, if you have any of those alterations with your disease. One of the other things to think about is what we call CNS recurrence, concern for the disease coming back in the brain. And I know Charu and I were talking right before we came in about what's the guidance for watching the brain for patients, stage 4 disease, even for earlier stages of disease, what to do. And I think that's something to seriously discuss with your team. If you go to what we call the National Comprehensive Cancer Network Guidelines, NCCN, and you look up what the surveillance recommendations are for most patients who have early stage disease that have gone to surgery, it's pretty broad. What they say is get a CT chest roughly every 6 months for the first 2 years. After that, you can consider spacing out. And then what to do for the brain, what they tell you is risk assessment. And so I think part of the risk assessment needs to be about if your disease has what we call these actionable genomic alterations like EGFR or ALK. I think that's a factor that needs to be considered for thinking about CNS monitoring or brain monitoring. Also, lymph node disease, lymph node status is something that I also think about. So for a lot of my patients, even with early stage disease, I am thinking about checking the brain because I can call in someone like Dr. Brownlee if we find something to act on it quickly when it's small, when it may not impact their quality of life and their neurocognitive function.
Okay, just a quick follow-up on that. So is it like a yearly brain MRI is kind of recommended? Okay.
Yeah, I think that's a good question. I don't think we don't really know for sure what the solidified guidance is. I think once a year is very reasonable. Sometimes I talk with my patients about doing a little bit more frequently. One of the challenges that we all face is insurance approval, right? I think that's a real challenge. And so I will advocate for my patients, if that is something that we decide together is important, and oftentimes we do, to at least push through and get that testing done on some frequency, some cadence.
Great, thank you. I'm going to give a couple more together just to kind of make sure we try and get everybody's answered if possible. So there's a question on computer-guided biopsy tech, ION. What are the possibilities for delivering therapeutics like chemo, mRNA, genetic modification, et cetera, directly to the nodule to kill cancer cells? And that's more on the personalized kind of, I think, space. Another one is, I think there's on proton versus SBRT radiation, that there are 2 or 3 folks that are very interested in understanding what your thoughts are on that. So let's start with that. Thanks.
So ion bronchoscopy is a technology that's available. I think it came out really within the last 10 years. The benefit of it is it's better than the prior technologies of getting to the nodule, to biopsy. There are technologies available where you can provide local energy to small tumors in patients who may be high risk. There are various companies that produce those technologies. Studying those and comparing them to surgery hasn't been done yet. So it's sort of probably in the next 5 to 10 years coming out. Delivering chemo, I don't know if that's really a thing. I think it's largely just local energy thing. But this is a systemic disease. I think it's really, Dr. Singhi's point is really important, is these diseases are through the bloodstream, and whether we can document or not that there's circulating tumor or not, these diseases can go anywhere. And so following these things closely, especially with brain involvement when patients may have no symptoms, is very important.
To be very brief on protons. So proton is a different particle that we can use with radiation therapy that has the ability of us to have a stopping dose. So the radiation doesn't pass all the way through the body, so we can potentially avoid normal tissues more effectively. Unfortunately, this technology is expensive to generate. It involves a cyclotron and a lot of space. So in Texas, we have one in Houston, and we have one here in Dallas. So we do refer patients when it is meaningful. Some people in different areas, it could be very cumbersome to get to a proton center. In the chest domain, there's not a huge benefit to proton therapy. It's more commonly used when we're dealing with brains in children or areas where we're retreating the same area twice. With SBRT especially, the treatment is so targeted, there's very little normal tissue dose in this setting.
Great, thank you. To the audience here and to the audience online, I'm going to encourage you to continue sending 1 or 2 last questions if you have, because we're getting through them much faster, and I see some of you online. In fact, I think I see my family member online because there's a question with my name on it, and I'm here. So I think I asked her, are you going to be able to join? So if you allow me a question from her as a survivor. Anyway, what cutting-edge tools or interventions are showing promise for cancer recurrence detection or prevention, even if they're not yet standard practice?
Yeah, this is a great question. We're starting to think a little bit more about what we call mRNA vaccines as well, right? And I think that's a really promising avenue. So you may have heard of mRNA vaccines for the COVID vaccine, right? Where we're trying to, prevent you from getting really severe bouts of COVID and all the symptoms and all the problems that happen with that. It's using the same technology, but what it's doing is it's trying to rev up your immune system and recognize specific tumor antigens or proteins from your specific tumor after you go to surgery. And I think that's a really promising field because, I showed you about PCR and MPR, those ideal goals that we're hoping for, that if I give you some treatments up front and then we get the tumor taken out and then we see that there's no tumor cells left behind, maybe 10% or less left behind, but that doesn't happen for everybody. So PCR on average happens in about 20% of cases, 20 to 25%. So that means that the majority of patients don't get that satisfying result after they've gone through drug treatments, after they've gone through surgery, and they still see some tumor that's alive. And so the question is, what to do after? Yes, we can continue the immunotherapy, but can we add to it with things like mRNA vaccines? And so I would encourage you to think about trials that are related to these mRNA cancer vaccines. I think that's an interesting space. I don't know if you guys have other thoughts.
I would just say for surveillance, in addition to imaging, these blood tests, looking for tumor DNA in the blood is a promising area that's being used across all cancer types, and it's in the lung field as well.
Oh, great, thank you. So just to clarify, when you mentioned that, I think you mentioned the MRD tests, some of the people that were outside. Okay, and there is kind of a pros and cons, right, and false negatives, which we discussed earlier, but you got to take it with a pinch of salt. One other question, the last one I think I have here, again, anyone coming in, please go ahead and send that. Since all 3 of you practice in Texas, are any of you involved with lung cancer treatment research that has received CPRIT funding?
I'm co-investigator with many of the lead investigators for the CPRIT. I'm sure you are too, Dr. Waters. UT Southwestern is also involved with that, and I don't know Dr. Brownlee, but it's a great avenue dedicated to cancer research specifically for patients and their loved ones in the state of Texas, and it's a really promising way to encourage cancer research, and so we're really grateful to have those funds at our institutions.
Okay, actually, one came in. Is there any alternative to Tagrisso as a TKI? Is Tagrisso considered chemotherapy?
Oh, that's a great question. Okay, so Tagrisso osimertinib is what we call an oral targeted therapy. So that's a different bucket of drugs. This is not chemotherapy. Remember, chemotherapy, guys, is what it's doing is it's non-selectively killing the fastest growing cells, and that happens to be the cancer cells. But it also kills other fast growing cells like your hair, which grows really fast, right? The gut lining as well too, which is why you can get nausea or diarrhea. That's what we call chemotherapy. Then we have targeted therapies. Osimertinib, Tagrisso is one of those, and it's very specific. It's very selective. It's going after a particular protein or pathway that's highly expressed on these cancer cells that's teaching your cancer cells to grow and grow and grow, and it's shutting down that pathway. So this is a separate class of drugs that we call targeted therapy.
Great, thank you. And our very last question today, actually bringing it all together, is on personalized medicine. You know, precision medicine, personalized medicine, immunotherapy being pretty new, like the last 80s, right, and kind of really coming in strong. What do you see in the future? Like, you know, 1953 when the Cancer Research Institute came out, what are the cutting edge spaces that somebody, you know, who is a survivor or caregiver, how do you navigate this by yourself, also taking agency in this space, you know, kind of becoming a builder, becoming an activator, which I think gives a lot of benefit to the individual, in my opinion. Thank you.
I can go first. You know, I think it's incredible. This word empowerment we use a lot for patients and care partners, and sometimes it adds a lot of stress that, you have to be an empowered patient. It doesn't mean that you need to know everything. What it means is that you need to feel heard and you need to feel included by your care team. I feel very strongly about that, right? So empowered doesn't mean you have to know everything. It just means that you need to be included. And I think feeling that inclusivity in your cancer care is really important, and having an advocate, if you're the person that's shy and you're the patient, bring that person that's loud from your family to come in the room and to talk with you, because you can see that there are so many advancements that are happening. If I was up here, like I told you 5 or 6 years ago, we weren't talking about personalized medicine and early stage lung cancer, and now we are. We're talking about EGFR, we're talking about ALK, we're talking about biomarkers that are beyond that, we're talking about vaccines. So this field is moving in real time before our eyes, and you want to make sure that you're with a care team that hears you and that's also up to date on all the advancements, right? And so I think that would be my advice.
Thank you so much. That wasn't meant. Audience, please help us in giving them a huge round of applause. Thank you.